Good afternoon. I would like to make presentation frequency of Bruxism among school children in Tirana school, which is prepared by me and my colleague, Faculty of Stomatology. What is the Bruxism? Term Bruxism was an old Greek word which means to grind or opposition rows of upper and lower molar teeth. The glossary prosodic terms define bruxism as parafunctional tooth grinding habit. The mechanism of development of bruxism. This is behavior that occurs during the day. This habit could occur during the day or night and can consist of semi-voluntary clashing or lateral tooth grinding movement. Early theories suggesting that bruxism was related to general malocclusion have been disproved, although in some isolated cases interference may play a role of its onset. What has been observed from different studies during last years, the causes of pathology of bruxism have been determined from the different factors that lead its occurrence are generic predisposition, sleep architecture, for example, microarousal occurring during the sleep. Psychological factors are stress, environment factor, CNS catalemia, brain trauma, drug effects example, antioxidant medication. Bruxism is also considered as lateral behavior that simulates salivation during the sleep. One experimental study involving induction of esophageal acidification has shown that bruxism episodes increase this acid stimulation, suggesting that reflux may cause bruxism behavior for individual and abnormality. Material and methods. We have studied about 226 patients, 4 until 12-year-old children, during 2014-2015. Patients completed a questionnaire which contained implicit data of the age of kids, sequence birth, medical history, also parents' age, education, and so. The second part was questions related to the time of bruxism during day or night, manifestation, distress, difficulty, the family history of bruxism, ATM joint disorder, psychological disorders, etc. ATM joint disorders were considered as jaw clinging, pain tendencies in muscle, limitation in mouth opening. In psychological disorders include rapidity, seclusion, sadness, neurophobia, crying, etc. Chi-square test was used to compare differences in proportion and was used AP values is less as 0.05. Results of discussion. A total of 226 kids were included in the study. 60% of patients were girls, 38 boys, with average age 6.4. Bruxism began in these children at the age 4.5 years. As reported by parents, 25%, 95% of children showed bruxism as parafunctional habit, which is shown in figure 1. There was no significant relation between the gender, the sequence of birth, father's age, and parents' education, etc. 9% of the children had fathers with bruxism history, 89% mothers with a bruxism history, and 2% have both parents of bruxism. A significant correlation was found between the family history of bruxism and its prevalence was 0.01. The prevalence of bruxism was 22% in children with history. figure, prevalence of bruxism, 85% in children with both parents' history of bruxism. According to the parents' report, 87% of children with bruxism had a history of distressing events in their life. 30% of children with bruxism didn't report any history of distressing events in their life. The difference between these two groups was significant, p 0.01. Oral habits were reported in 20% of the children. Nail beating was the most frequent habit in the prevalence, 11%. The prevalence of bruxism in children with ATM, 60%, 61%, 20% of the children was without ATM. In our study, psychological disorders was about irritability, 35%, while crying easily, 27%, hyperactivity, 7%. Chronic bruxism. Chronic bruxism have these symptoms: tooth wear, mild to severe, tooth cusp fracture, attached gingival resension, tooth mobility, fracture restoration, mastificatory muscle pain, ATM disorders. Additionally, the literature includes other symptoms such as opening limitation, temporary headache, ear symptoms, migraines, neck pain, insomnia, depression. Author San at colleagues found high prevalence of sleep bruxism among preschool children, about 36%. The researchers concluded that pediatric sleep bruxism may serve as a warning sign for possibly adverse health condition and need for early intervention. Treatment of bruxism. Exist some ways: psychological, medication, prosthetic. Psychological treatment is done through a psychologist. This is done in order to avoid habit that kills carers. Medicinal treatment involves the use of muscle relaxing. Prosthetic treatment involves the use of relaxing spring, which was held night and long to habit are removed. Conclusion: the diagnosis of bruxism is descriptive in nature, contingent on the prevalence of the symptoms such as no-digit tooth grinding, pain in ATM or jaw musculature, temporal headache, tooth hypersensitivity or mobility, and poor sleep quality. These subjective symptoms are coupled with clinical signs such as abnormal tooth wear, tongue indentation, the presence of the linear albar monk pitting plan, and the buccal mucosa gum retention, masseter hypertrophy. In diagnosing bruxism, particularly as sleep disorders, there need to be a well-defined exclusion criteria that separate bruxism from the other sleep disorders, such as sleep apnea, epilepsy, etc. Effective management of bruxism relies on the recognition potential causative factor associated with the condition, for instance, since daytime, etc. The last slide. As conclusion, we may to say, in the patient with sleep bruxism, appropriate intervention may include appliance therapy and medication. In passive patient with medication or drug include bruxism medication, withdrawal or change the medical type in one lead likely to cause bruxism should be considered. In street drugs are involved with intervention should include drug and perhaps psychological counseling. Thank you for your attention, and if somebody has an question, please don't hesitate to contact me immediately. Thank you again.